large intestine. Okay, so motility in the colon simply describes the different types of motility that you can appreciate in the colon or large intestine. So like I said, that the colon, it's a large intestine, so it's very big in terms of volume. So it will function as a reservoir for residues of meals that cannot be digested or absorbed. So anything that is not being digested or absorbed in the small intestines, it will be pushed into the large intestines. Then the large intestines, they are also responsible for certain types of digestion and absorption of water. So there's a lot of absorption of water in the large intestine. So I told you to say that 90% of the fluid is being absorbed in the large intestine. So if you have chyme that is containing, let's say 100% of fluid, so that 90% of the fluid from the chyme will be absorbed in the large intestine. So there's a lot of water absorption in the large intestine. So that is required because now this is the end part of the intestines. So you need to absorb as much water as you can and also other electrolytes. So there are minerals and other electrolytes that are also absorbed by the large intestine. Okay. So the semi-fluid chyme that is being emptied into the colon, it will be converted into the semi-solid feces. So now this is into the process of producing the fecal material by absorbing as much fluid as possible. I think I mentioned that yesterday, so we proceed. So this is a diagram that is showing innervation to the large intestine, of which I mentioned again to say the proximal parts of the large intestine is innervated by the vagus nerve. So when you're talking of the cecum, the ascending colon, and some portion of the transverse colon is mainly innervated by the vagus nerve, which is the cranial nerve number 10. It will be responsible to modify and also to regulate the enteric nervous supply to the GIT. So the enteric and the submucosa can also be modified by the vagus nerve. The vagus nerve, we have the parasympathetics, which is part of the cranial nerve. Then I also told you to say that you have the sacral nerves, which are part of the parasympathetics that are innervating the distal part of the large intestine. So the distal part is talking of the descending colon, the sigmoid colon, the rectum, and the anus. So all these structures, they are heavily innervated by the pelvic nerves. The pelvic nerves, they are originating from the sacral region of the spinal cord. So the segment S2, S3, and S4 are the ones that are providing those parasympathetics to the distal part of the large intestine. So this part of the large intestine, I mentioned to say it's heavily innervated by the parasympathetics. Why? It's because it's involved in defecation reflex. So the defecation reflex requires a lot of parasympathetic stimulation that will bring about the release of acetylcholine, and those acetylcholine, they are going to stimulate the enteric plexus so that you have an increase in the motility. So the contraction of the rectum is going to increase, the contraction of the sigmoid colon is going to increase. That will push now the fecal material into the rectum, stretching the rectum and initiating a defecation reflex there. Then if the rectum is contracting, it will push the fecal material against the opened anal sphincter. But remember, we said that there are two anal sphincters. We have the internal anal sphincter, which is innervated by the parasympathetics. So it's controlled automatically. So it's under the control of the autonomic nervous system. But the external anal sphincter, they are skeletal muscles, so you can control them with your somatic neurons, which are part of they are coming from your conscious, from your higher center, from your brain. So using your conscious, you are able to generate information that can inhibit the contraction of external anal sphincter muscles so that they open up. So the anus is going to open up and the fecal material will be pushed outside. That will be the actual defecation process that we'll be discussing today as well as we proceed. So the motility of the colon or the motility in the large intestine, I think we mentioned to say you can divide the large intestine into the cecum and proximal colon. So the motility in the cecum and proximal colon. So the most contractions here in the large intestine are segmental. So segmental contractions is due to the contraction of those house striations. Remember those segments of the large intestines, pocket-like structures of the large intestines, they are called house striations. So some of the house striations will be contracting, others will be relaxing. Then there will be exchange of relaxation and contraction between the house striations. So that will bring about mixing contractions. And those mixing contractions, they are not interested to propel the chyme or the fecal material from point A to point B towards the anus. They are just interested in chopping the chyme so that you expose more chyme to the absorptive surfaces in the mucosa of the large intestine that is involved in absorption of water and electrolytes. So they are very effective at mixing and circulating the colonic contents than at preparing them. So here, this sentence is just telling you to say that these are interested in mixing the chyme, not necessarily to propel the chyme towards the anus. So that's why they are called mixing contractions or segmental contractions. The control of segmental contractions were already discussed, and also the functions of segmental contractions that was mentioned in the previous lecture. So you are able to relate now. So the mixing facilitates absorption of salts and water, like I've already mentioned. Localized segmental contractions divide the colon into neighboring ovoid segments, which are called house stria. So these are called house striations. So these are the segments that I was talking about. Say they are pocket-like structures of the large intestines that are involved in segmental contractions. So in the proximal colon, you have more of anti-propulsive pattern. So anti-propulsive, it means they are opposing the movement of chyme towards the anus, hence the name anti-propulsive. So these are more like reverse peristaltic contractions. So we have reverse peristalsis that is taking place there, especially in the cecum and proximal colon, and also segmental propulsions that are taking place there. So the reverse peristalsis, first, if you have a positive peristalsis, they'll try to move this chyme from the cecum towards the proximal colon. Then you can also have reversed peristalsis that will reverse the movement of the chyme. So it will be pushed back into the cecum, then it goes back into the colon. So that toasting of chyme will provide enough time for the colon to absorb a lot of water. So water absorption and electrolytes absorption is taking place more in the proximal colon and part of the cecum. So this chyme is retained in the proximal colon, and this retention facilitates absorption of salts and water. So the retention of chyme within the cecum and the proximal colon, because of reverse peristalsis that are taking place there, will facilitate absorption of salt and water. That's why now the chyme or the ingesta will be converted from semi-fluid into the semi-solid fecal material, which is solid now, or hard fecal material. What about the motility of the central and distal colon? So the central is the transverse and part of the descending colon. So you have central and distal colon. So what kind of motility are you going to appreciate there? So here you have more of mass movements. So mass movements, like I explained, these are peristaltic contractions or movements that are taking place within the large intestines. So they are simply peristaltic contractions. So a mass movement fills the central and the distal parts of the colon with the semi-solid feces, because now the water and the electrolytes have been absorbed by the proximal and the cecum or the colon, but now the semi-solid fecal material is now being pushed into the distal and central colon. So what you're going to have here are peristaltic contractions. Then you also have segmental house stria contractions that will need the feces and facilitate absorption of the remaining salts and water. So even here, there is a bit of absorption of salt and water. So what remained from the proximal colon, when the chyme is pushed into the central and distal colon, there is also some mixing or segmental contractions there that will expose the remaining water and electrolytes to the absorptive surfaces so that more absorption is taking place. So it means the fecal material is becoming more solid now as it's going towards the rectum. So mass movements then they will sweep the feces towards the rectum. So you have more of this peristaltic contraction that is now pushing the almost solid fecal material towards the rectum because much of the water now has been absorbed. So if water is being absorbed, you have this solid fecal material that is overstretching or distending the colon. That will stimulate stretch receptors, and then they will have more contraction, and those contractions now will push the almost solid fecal material towards the rectum, because now this fecal material is ready to be excreted from the body or to be removed from the body. So during ileocecal valve emptying, we say that the ileum is emptying into the cecum. So this chyme that is being emptied into the cecum is in fluid form or semi-fluid form. So this semi-fluid form chyme, it has to move. So those peristaltic contractions, they'll start pushing the chyme. And also you have segmental contractions that are increasing absorption of salt and water. So you know to say salts and water are being absorbed here. By the time the chyme is reaching the transverse, which is the central and descending part, you have less of water. So you have more like a mush kind of fecal material. Then more water is being absorbed in the central and distal colon. So more water is being absorbed, and then that fecal material will be now converted into semi-solid, almost solid. Then water absorption continues. The fecal material now will be pushed into the rectum. That is going to trigger a defecation reflex from the rectum. Okay. So the movement in the large intestine. So this is just a summary of the movements, of which we said we have mass movements. These are strong contractions, peristaltic contractions that are common after a meal. So after a meal, you find that these mass movements, they are going to increase. Why? It's because of certain reflexes, like gastrocholic reflexes. So we said, as you are eating, there are certain information that will be generated from the stomach, and then it will go to the colon to cause an increase in the motility of the colon, to evacuate the colon so that the colon should be ready to receive another chyme that is coming from the meal that you are eating. So you find that after you are eating, the mass movement in the colon is going to increase because of those reflexes. That depends on the integrity of enteric plexus, especially the myenteric plexus, that is between the longitudinal and the circular muscles. Then you also have local reflexes. So these local reflexes, they are due to distension and the presence of chemicals that are coming from digestion. So digestion byproducts like amino acids, fatty acids, you have glucose. So they can also stimulate certain sensory receptors. Then that can increase motility. So you have local reflexes. So for instance, you can have gastrocholic reflexes, which is also an example of local reflex. You have the duodenocolic. All these are going to increase motility in the large intestine. Then if the fecal material has been pushed into the rectum, that will now initiate a defecation reflex. So the defecation reflex is due to distension of the rectal wall by the feces. So the fecal material that is being pushed into the rectum, it will cause distension of the rectum. Then that can stimulate the parasympathetics that will release more acetylcholine to cause contraction of the smooth muscle cells to squeeze now the fecal material against the anal sphincter muscles so that they open up and you are able to remove whatever is contained within the rectum. But if the external anal sphincter muscles is not opening up, it's contracting so much because maybe the environment you are in doesn't allow you to defecate. So due to social challenges, sometimes you would want to force yourself not to defecate, When that happens, the fecal material in the rectum will be pushed back into the sigmoid colon. So there will be more absorption of water. So if you are continuously inhibiting defecation, then you are going to end up with constipation, because more of water now will be reabsorbed. So there will be more absorption of water. If you have more absorption of water, you are having solid fecal material. So if this solid fecal material is so hard, sometimes it's very difficult for you to push it, to move it from one point to another point. That will bring about issues to do with constipation. Okay, so this is just a summary of the motility in the large intestine. But now let's move on to physiology of defecation. Physiology of defecation, just to add more information, because defecation process is very important. So here you need to remember, I told you to say the parasympathetics that are innervating the distal part of the large intestine, the rectum, the sigmoid colon, and the anus. We said is heavily innervated by the pelvic nerves, which are originating from segments S2, S3, S4. So they will provide those nerves that will innervate those structures. So those nerves are very important because they are involved in a defecation reflex, So because they are originating from the sacral segment, if you have spinal cord injury, or you have a patient with a spinal cord injury that is affecting maybe the cervical region, thoracic region, or lumbar region, it's not going to affect the defecation reflex. So you find that they could be paralyzed, but they are able to hold on to the fecal material. Why? It's because the nerves that are innervating those structures that are involved in defecation reflex, they are still intact. So that's the clinical implication. But if you have a patient that has got a spinal cord injury and is affecting the sacral parts of the spinal cord, that can also compromise the defecation reflex. So you find that such patients, they will start defecating on their own. You know, they don't have control over that, because the region that is supposed to interpret that information, the integratory centers, are damaged. So you need to know the clinical implication of that. Okay, so defecation. So you can see this boy who's defecating outside. It's called OD, or open defecation. But for him to defecate, there are certain mechanisms that are triggered there. The moment he sees people, he can even stop defecating. Why? It's because you can use your conscious also to control defecation. So I want to explain the physiology behind defecation. So just relax and enjoy the information. So let's start. So defecation is defined as the final act of digestion by which organisms eliminate solid, semi-solid, or liquid waste material from digestive tract via the anus. So it's the process of getting rid of the waste materials that are coming from digestion. So anything that was not digested, anything that was not absorbed, needs to leave the body. So it's going to trigger a defecation reflex. So this is how you define defecation. So humans, they expel feces with a frequency varying from a few times daily to a few times weekly. So it depends with a person. There are people who defecate at least once a day. Others, they will defecate maybe twice in every 4 or 7 days, maybe twice a week, maybe 3 times a week. So this frequency is dependent on how much food you are eating and the type of the food that you are eating, the quantity, the type of the food that you are eating. So if you are always having meals, you find that at least each and every day you have to go and defecate. But I told you to say that the moment you introduce food in the oral cavity, it takes about 7 to 10 hours for it to reach the rectum. So it will spend about that time in the GIT. That's why I'm telling you to say, every time you eat a meal, especially a heavy meal, 30 minutes after eating, you have that desire to go to the toilet. Why? It's because of gastrocolic reflexes. So the more you eat, the more the stretching on the stomach, and then you have gastrocolic reflexes that will cause motility in the colon. If there's motility and then there is ingesta there, whatever is within the colon will be pushed into the rectum. Then it will trigger a defecation reflex. So it doesn't necessarily mean that after eating 30 minutes, you go to the toilet and then you are defecating the food that you just ate. It's not like that. It's because there were some residues of fecal material that were still contained within the colon. So when you eat, the motility to the colon is going to increase, then that can trigger a defecation reflex. If you have enough fecal material in the colon that is being pushed into the rectum. So in most cases, the rectum is empty. So if the fecal material has been pushed into the rectum, then the environment is not conducive for someone to defecate. You've had instances whereby you are in class, but you just feel like going to defecate. But because you're in class, you hold on. So if you hold on, then the fecal material that is contained in the rectum can be pushed back into the sigmoid colon. Then more reabsorption of water takes place there. So that's the reason why sometimes you, at one point, you feel like going to the toilet, and then you just decide not to go. Then at next time, you find that that age, that desire to go and defecate disappears. Then it will come later on. Why? It's because in most cases, the rectum is empty. When there's fecal material being pushed there, it will trigger defecation reflex. If you're not going to the toilet, it will be pushed back into the sigmoid colon. But sometimes you reach a breaking point whereby you can't ignore because the stimulus is so strong. So if there's a buildup of fecal material in the rectum, even if the rectum is contracting to push it back to the sigmoid colon, if in the sigmoid colon there's still a lot of fecal material load, then you just have to go and defecate. So it reaches a breaking point whereby you can't ignore it. You just have to go and defecate. Okay. So the feces are forced into the large intestine and stored in the sigmoid colon. So this is where storage of fecal material is stored in the sigmoid colon and not the rectum. So in most cases, the rectum is empty. So there are certain people that will take advantage of that because they know to say the rectum is empty. You've seen gay people, a man having sex with another man using the anal route. So they know to say that the rectum is always empty. Maybe, I don't know, maybe they understand a bit of physiology, who knows? So they take advantage of that, then they'll start pricking down there. You see that? So this is just to tell you to say in most cases, the rectum is empty, okay? So the fecal material is being stored in the sigmoid colon. Okay, so movement now from the rectum to the anus. So the rectum is a distensible masticular tube that acts as a reservoir for waste material. So the rectum also can store a bit of fecal material, but not for a long period of time. Like I said, in most cases, it's empty. So as the rectal wall expands, we're feeling stretch receptors from the nervous system located in the rectal wall stimulate the desire to defecate. So when there's fecal material that is being pushed into the rectum, there's distension of the rectum that will stimulate the stretch receptors, and those stretch receptors are the ones now that will go and stimulate the defecation centers. Even the desire to defecate is going to increase. Now you are aware to say that I need to go to the toilet. Okay, then you go to the toilet. So we proceed. So you can see this is the rectum and the anus down there. So in the anus, you have internal anosphincter muscles and external anosphincter muscles. The external anosphincter muscles, they are innervated by somatic efferent neurons. So you can see the somatic motor neurons that are innervating the external anosphincter muscles. That's why you can control them using your conscience. But the internal anosphincter muscles, they are innervated by enteric neurons and also autonomic nervous system. So the enteric neurons, they are neurons that are intrinsic to the GIT, so you don't have control over them. If the rectum is distended, they will relax. But if the environment is not conducive, then you control the contraction of the external anosphincter muscles. Okay, so even in this diagram, you can still appreciate the internal anosphincter muscles and the external. The internal are smooth muscle cells the external are skeletal muscle cells. So the internal are the same circular and longitudinal muscle cells, okay, towards the end of the anus. The defecation reflex is summarized in this diagram. So let me just explain it from this diagram, just in case a question comes to say, can you explain the defecation reflex? So if it's an essay question, it's better you start by drawing. Okay, of course, you define whatever terminology is involved there, then you draw, then you explain from the drawing. That becomes easy for you to explain the essay, because you'll be just looking at the diagram, then you'll be just writing down there. So even the diagram will remind you the steps that you need to follow. So let's just use this diagram to explain the defecation reflex. So let's start now. So in this reflex, there are local reflexes and short reflexes that are involved in the defecation reflex. So the first thing is distension of the rectum. So we are starting here. So there are fecal material that are being pushed from the sigmoid colon into the rectum. That will bring about distension of the rectum. When the rectum is distended, it will stimulate the stretch receptors, because those stretch receptors, they are mechanosensitive receptors. So once they are stretching, they will be stimulated. So they will start an action potential. That action potential will be propagated via the sensory nerve fiber. So you have the sensory nerve fiber that are projecting to the myenteric plexus within the sigmoid colon and the rectum. So these are the ones that are involved in local peristaltic contractions. So if the sensory neurons is stimulating the myenteric, you know to say myenteric is going to stimulate the longitudinal muscles and the circular muscles in the sigmoid colon and the rectum, increasing peristaltic contractions. So you can see there is increased local peristalsis. So that is a strong contraction now that is trying to push the fecal material to the outside world via the anus. But we also have long reflexes. So we have short reflexes and long reflexes. The long reflexes, the sensory nerve fiber, when they transmit those action potentials or they fire those action potentials will be propagated to the central nervous system and also to the prevertebral ganglia. So within the central nervous system, it goes to the sacral region or the spinal cord. That's why you have the centers for defecation or defecation centers. So S1, S2, S3, and S4, those segments. So the centers, they will interpret that information to say, if there is overstimulation, then the rectum is over-distended. So it will generate a motor information via those parasympathetic nerves, which are pelvic nerves. There, the pelvic nerve, they will now release a lot of acetylcholine to the rectal, to the muscles of the rectum and sigmoid colon. So you're going to have an increase in the contraction of the sigmoid colon and also the rectum. Then at the same time, there is information that is being projected to the higher center. So the higher center, which is the brain now, it will be aware to say you're about to defecate because the defecation reflex has been triggered. So now there is information that is coming from the higher center. It could be inhibitory or stimulatory. So if the environment is not conducive, it will send a strong inhibitor, a stimulatory message to the external sphincter muscles to cause more contraction of external sphincter muscles because the environment is not conducive. But if you go to the toilet, you know to say now you can defecate. You find that there will be inhibition of the external sphincter muscles so that they relax. So if the internal sphincter muscles are relaxing and also external sphincter muscles are relaxing, that will open up the anus. Then the fecal material will be pushed. That is the actual defecation process that is taking place there. So you can see in this diagram that you have these somatic motor neurons that are innervating the external sphincter muscles. That will bring about inhibitory or stimulatory information. So if the environment is not conducive, they will stimulate these muscles to contract so that the anus doesn't open up. But if the environment is conducive, this somatic motor neuron is going to be inhibited to fire an action potential. the external sphincter muscle cells, they're not going to be receiving any stimulatory information, so they are going to relax. So once they are relaxing, if the internal sphincter muscles are also relaxing, the anus is going to open up, then the fecal material will be pushed to the outside. This is a summary of the defecation process. So we have gastrocolic reflex that moves feces into the rectum from the sigmoid colon. Then the stretch receptors are going to send a signal to the spinal cord. You have the parasympathetic nerves that will now cause contraction of muscles of the rectum and also relaxation of internal sphincter muscles. And the external sphincter muscles is voluntarily controlled depending on whether the environment is conducive or not. If it's conducive, it's going to relax. If it's not conducive, you have a strong contraction. Okay. But what happens in case of diarrhea? So sometimes you can have a diarrhea that could be infective diarrhea if there is bacteria that is proliferating within the rectum. There will be toxins that will be released there that will irritate the mucosa of the rectum. So if the mucosa of the rectum and the mucosa of the colon is being irritated, there will be peristaltic rash. There will be an increase in the contraction of the colon. So the entire colon will increase in motility. So if the motility is increasing and you won't have much of reversed peristalsis, so it means that there will be no enough time for you to absorb a lot of water. So the fecal material that is reaching the rectum, you find that it will still be semi-liquid form. So if it's semi-liquid form, what you are releasing to the outside is semi-liquid, that would be diarrhea. So there are a lot of causes of diarrhea. It could be an infection like cholera infection and other bacterial infection, or it could be that you have eaten some poisonous substances that are irritating the mucosa or the GIT that can also result into diarrhea. Sometimes it could be that there is some sort of miscommunication between the autonomic nervous system and the mesenteric nervous system, and that can also bring about abnormal contractions in the large intestines. Then there will be an increase in the movement of the chyme without providing enough time for absorption to take place. So you find that you can have a diarrhea. So the diarrhea is pathology. So in pathology, you're going to discuss that. So here we're interested in physiology. So you just need to know the normal so that you'll be able to differentiate from the abnormal. So the next year, if you make it to next year or next academic year, then you'll be able to appreciate some pathology in the GIT. Okay. Otherwise, we are done with motility. Once we are done with motility, we need to start looking at So the defecation reflex is summarized in this diagram, but I've already explained everything. So that's just your extra information. So moving on to physiology of vomiting. So I want to get done with motility. So vomiting is some special type of motility, which could be physiological or pathological. But in most cases, vomiting could be physiological because you are trying to get rid of certain things that you've eaten. So when you eat poisonous substances, some vomiting center can be stimulated. And once the vomiting center has been stimulated, it will trigger a vomiting reflex. So it's another reflex again. It's something that you don't have control over. Okay, so now let's go into the physiology of vomiting as opposed to defecation. So what is vomiting? Vomiting is the means by which the upper gastrointestinal tract rids itself of its contents. So the upper gastrointestinal tract can also get rid of its content via vomiting. So this is where reverse peristalsis comes in. So the contents that you can vomit can either come from the upper small intestine or it can come from the stomach. So the things that are in the rectum, it's very rare that you can vomit things that are coming from the rectum. So it's very rare that a person can vomit fecal material. Why? It's because the reverse peristaltic contractions in the upper part of the stomach is what is going to push the chyme back into the stomach. Then the stomach can contract. Then you'll be able to vomit things that are coming from the upper part of the small intestines. So the process involves stimulation of vomiting center and the vomiting center initiating the vomiting reflex itself. So there are centers in the brainstem that are responsible for vomiting. So once there are stimulus that are stimulating the vomiting center, those stimuli can initiate vomiting by stimulating the vomiting center. So the sensory signals that initiate vomiting originate mainly from the pharynx, the esophagus, the stomach, and the upper portions of the small intestines. So these are the portions that will contain sensory receptors that can be irritated, or maybe it could be pain, or whatever it is that is irritating these receptors. Then they can trigger an information that will be generated via the sensory neurons. It will be projected to the brainstem, where the vomiting centers are located. Then once the vomiting centers are stimulated, they will trigger vomiting reflex itself. What could be the causes of vomiting? So what are some of the causes of vomiting? So there are many causes of vomiting. So the following are some of the causes. The first one being drug-induced. So some of the vomiting can be induced by drug. So drug-induced vomiting. Opioids like morphine, codeine, nicotine, and excess alcohol, antibiotics. So all these drugs, they can initiate vomiting. Okay, so they will act as a stimuli to stimulate vomiting. So some of them, they will act as toxins, and the toxins can be detected by the chemoreceptor trigger zone. The chemoreceptor trigger zone communicates with the vomiting center. So whatever is going to stimulate the chemoreceptor trigger zone, it can also go and stimulate the vomiting center, because there's a connection between the chemoreceptor trigger zone and the vomiting center. There are neurons that are connecting them. So you find that once the chemoreceptor trigger zone is stimulated, then those neurons will stimulate the vomiting center, then that will initiate vomiting itself. Okay. Then what are some of the causes of vomiting? So we said one of them, it could be the drugs, drug-induced vomiting like morphine and codeine. So when you're giving these drugs, you should also know to say that they can stimulate vomiting in these patients. So some of the drugs should be given with anti-emetic drugs. So you also have anti-emetic drugs that will inhibit vomiting. So if you're giving a drug that can initiate vomiting, you can also give a drug that will inhibit vomiting, so that you don't have these patients to start vomiting in their wards. Then increased intracranial pressure, so due to hemorrhage. So if there's hemorrhage, there is some blood that is being released to the brain tissue because of hemorrhage. That can also stimulate the vomiting center. So vomiting following injury is considered to be a dangerous type of vomiting, because that would indicate swelling or bleeding in the cranial cavity. So if there is swelling or bleeding in the cranial cavity, that can also stimulate the vomiting center. So after road accidents, then you have a patient with injury in the head, then you realize to say that they start vomiting. That could be a bad sign, because it will tell you to say there could be some hemorrhage in the brain, or bleeding in the brain, or swelling in the brain that will stimulate the vomiting center. So it's not a very good sign. Then irritation of the stomach in the duodenum. So if you have toxins or certain chemicals that are irritating the mucosa or the stomach and the duodenum, that can also stimulate vomiting, because those receptors can be stimulated, then they will transmit action potentials to the vomiting center that will initiate vomiting. So allergies, liver problems, pancreatitis, all that can also cause vomiting. Even certain chronic renal diseases, it can also trigger vomiting, because if the kidneys, they're not operating very well, they are filtering less of waste products, and some of these waste products, they'll start accumulating within the body, they'll become toxic, then they can go and stimulate the chemoreceptor trigger zone. Then the chemoreceptor trigger zone, I've already told you to say that there's a connection with the vomiting center in the brainstem. So once the chemoreceptor trigger zone is receiving a lot of toxins, then in turn, it will go and stimulate the vomiting center. That will proceed to initiate the actual vomiting reflex. So vomiting center lies in the reticular formation or the medulla in the brainstem. So in the medulla of the brainstem, that's where you find the vomiting center, which is part of the reticular formation. So it consists of various scattered groups of neurons in this region, and that control different components of vomiting act. So these neurons, they will control different components of vomiting act, because there are a lot of muscles that are involved in vomiting as well. So the chemoreceptor trigger zone, this is what I was talking about, the CRTZ. The CRTZ, or the chemoreceptor trigger zone, which is also known as the area postrema. Area postrema lies outside the blood-brain barrier. So remember, in the brain, we have the blood-brain barrier, whereby the astrocytes are covering the capillaries, and then you have the endothelial cells there. So that will provide a barrier. So it's very difficult for certain drugs to cross the blood-brain barrier. It's very difficult for certain molecules to cross the blood-brain barrier. So that blood-brain barrier is going to protect the brain from toxins and other things. But the chemoreceptor trigger zone, it lies outside the blood-brain barrier. That will allow certain toxins to move from the cardiovascular system or from the capillaries to go and stimulate the CRTZ, the chemoreceptor trigger zone. So the chemoreceptor trigger zone can also stimulate the vomiting center and initiate vomiting reflex. So there is a connection, like I said. So the vomiting center is part of the reticular formation that is found in the medulla of the brainstem. So you can see here, this is the vomiting center. Then the vomiting center is receiving stimuli from different organs or from different systems of the body. So there are a lot of systems that can stimulate the vomiting center. So let's start with the gastrointestinal tract and the heart. So in the heart, in the GIT, there are mechanoreceptors, there are chemoreceptors, then there are also serotonin receptors. So these receptors, when they are stimulated by toxic chemicals or by stretching, that will cause pain. They can generate a sensory information via the cranial nerves, especially the glossopharyngeal and the vagus nerve. The glossopharyngeal is the cranial nerve number 9, the vagus nerve is cranial nerve number 10. So via these cranial nerves, they stimulate the sensory information will be transmitted to the vomiting center. And once the vomiting center is stimulated, it can initiate vomiting. And then you also have information that is coming from the central nervous system. So the central nervous system, it could be the cortex, the thalamus, the hypothalamus, or the meninges. In the meninges, maybe there's inflammation there. In case of meningitis, there's inflammation. It could be some toxins or cytokines that can trigger vomiting. So from the central nervous system, it can also send sensory information to the vomiting center to stimulate vomiting. So from the cortex, you know, to say site of bad scene, maybe there's rotten food, there's a dead person who's been dead for maybe 2 days, 3 days, they're smelling and stuff like that. Those information gets to the cortex, and the cortex will interpret that information to be a bad scene. Then it can generate a vomiting reflex by sending sensory information to the vomiting center. So just from the cerebral cortex, there could be some information, stimulatory stimulation, that goes to the vomiting center. That's what I mean. Then the vestibular system, which is part of the vestibulocochlear nerve, you know, to say that the vestibular system is found in the ear. So in the ear, you have one part that is involved in hearing and another part that is involved in balance. So the vestibular system is the one that is involved in balance. So you have those semicircular channels that contain hair cells. So you agree with me to say certain motion can actually trigger vomiting. You've heard of Motion sickness. Motion sickness. There are certain individuals when they jump into the bus or they jump into the vehicle, once the vehicle is moving with a greater speed, you find that it can actually trigger vomiting. Some of them, they'll start vomiting. You've seen people vomiting in a bus, not so. Why? It's because the vestibular cochlear system or the vestibular part is involved in vomiting via the H1 receptor and M1 receptor. So they can generate information, especially when the brain gets very confused because you are seated in a bus or in a vehicle that is moving. So the information that is coming from the spindle fibers, from the joints, from the Golgi tendon organs, is sending information to the brain to say, you are not moving, you are stationary, you are not making any movement. Then the information that is coming from the vestibular cochlea or from the vestibular part, from the semicircular canals, it's telling you to say that you are moving at the greatest velocity. So the brain will start getting confused. And in the process, it can trigger vomiting reflex itself. And then you start vomiting. So that's motion sickness. Then we have chemoreceptor trigger zone, which is called the area postrema. There are also receptors there, chemoreceptors, the D2 receptor, NK1 receptor, and serotonin receptor. So there are chemicals that can stimulate these receptors. And once they are stimulated, there is a connection between the chemoreceptor trigger zone and the vomiting center. So it can also send sensory stimulatory information to the vomiting center. Then the person will vomit. Then the actual vomiting center contains other receptors. So you have the H1 receptor, M1 receptor, NK1 receptor, serotonin receptors. So these receptors can be stimulated by neurotransmitters. And the neurotransmitters are being released by the neurons that are communicating with the vomiting center. So once the receptors are stimulated, then the vomiting reflex will be triggered via the parasympathetics, motor efferent activity that are going to increase. And then there are certain muscles that will start contracting, other muscles relaxing, that will bring about the actual vomiting. Okay, so the vomiting, I've already talked about the chemoreceptor trigger zone and the vagus nerve that can be stimulated, the vestibular system. So you have the vestibular cochlear nerve that is also involved in vomiting. The vagal, the enteric nervous system is also involved because the motility is going to increase during vomiting. Okay, so now let's just look at the phases of vomiting. Phases of vomiting. This is just a summary of vomiting and the factors or systems that will have an effect on the vomiting center. It's basically the same information with the previous slide that we are looking at. So we said chemoreceptors, we have chemoreceptor trigger zone that is sensing some toxins. It could be they're coming from drugs or metabolites that are stimulating the chemoreceptor trigger zone. It's area postrema, so it's outside the blood-brain barrier. So those toxins, they can move from the capillaries to come and stimulate the chemoreceptor trigger zone. Then there are sensory projection to the vomiting center. They are stimulatory to the vomiting center. Then the vomiting center will initiate vomiting. Fear, pain, cerebral cortex will send stimulatory information to the vomiting center. Then you can vomit. Motion sickness, I've already explained. The vestibular apparatus, those semicircular canals that contain hair cells, once they are stimulated more, then the brain is confused. Then it can also send stimulatory information to the vomiting center. Then gastric irritation. So if you have irritants in the lumen or the GIT, they will start irritating the mucosa or the GIT or the stomach. So gastric irritation or duodenal irritation, that can also cause vomiting. And then also distension. So if you have over distension of the GIT via the vagus nerve and the splanchnic nerves, they can send sensory information to the vomiting center to trigger vomiting itself. Phases of vomiting. What are the phases or stages of vomiting? So there are three major stages of vomiting. The first phase or stage is called nausea. So you have nausea. This is just a sensation, the intrinsic feeling that you're about to vomit. Not that you are vomiting, but there's just that feeling that you are just going to vomit. You can even say I'm about to vomit, but you're not yet vomiting. So that is called nausea. Then you can even start sweating and salivation. So sweating and salivation is because of the sympathetic and the parasympathetic stimulation. So the sympathetic stimulation, it will cause contraction of the sweat glands. That's why you're going to start sweating. Somebody who's about to vomit, you even start sweating, then you start salivating, start producing a lot of saliva. Then wrenching is whereby you have contraction of the abdominal muscles, contraction of the stomach. You can start feeling now that the vomitus is about to come out. So that sensation that comes to say there are some things that are coming towards the oral cavity, that is called wrenching. Then the emesis or vomiting is the expulsion of gastric content through the mouth. So the actual act of vomiting is called emesis. So emesis, so antiemetic drugs, it means they are against the vomiting. So you can use antiemetic drugs to inhibit vomiting. Okay, so emesis is the actual act of vomiting. So a bit of information on nausea. So nausea is an unpleasant sensation of wanting to vomit. So it's very unpleasant sensation. You just feel like vomiting, and that feeling is not good, trust me. So it's very unpleasant sensation of wanting to vomit. So it's often associated with cold sweat. So it's cold sweat because the sympathetic is being stimulated, that will bring about contraction of the sweat glands, but not that your temperature has increased. No, you start sweating, not that the external environment is very hot. It's not a thermoregulatory mechanism here. You are sweating because the sympathetic has been stimulated. Once the sympathetics have been stimulated, you start sweating. Then at the same time, there's pallor and salivation. So pallor, it means there's some sort of blood supply to the skin is going to reduce because of the same vasoconstriction. So blood supply to the skin is going to reduce, so you can have pallor. Salivation, you know, to say sympathetic and parasympathetic is going to increase the volume of saliva production. There will be loss of gastric tone. There will be duodenal contractions, then the reflux of intestinal content into the stomach. So the intestinal content now is moving back into the stomach. Then nausea is preceded with vomiting. So after nausea, then you have wrenching, then vomiting itself, that you'll be able to see the vomiters coming outside the oral cavity. So the system that brings about the loss of gastric tone, of gastric relaxation, is the efferent part or the long loop intestinal reflex that relaxes the gut during food intake. So you know, to say the stomach will be relaxed, things are moving from the intestine into the stomach, then later on the stomach will contract also when the abdominal muscles are also contracting. So wrenching is a strong involuntary effort to vomit. So now the muscles come in. So you had nausea, which is just a desire, unpleasant desire to vomit. So you have just this intrinsic feeling that you're about to vomit, not necessarily a desire, but it's an unpleasant feeling that you're about to vomit. Then wrenching is a strong involuntary effort to vomit. So there's that effort that comes because contraction of abdominal muscles, you know, you have reverse peristalsis, trying to push whatever is in the stomach back into the esophagus. So during wrenching, the abdominal muscles, the chest wall, the diaphragm, all contract without any expulsion of gastric content. So here now you have contraction of these muscles, but you are not yet vomiting. So that part is called wrenching. Then the final part is called emesis. So emesis or vomition or vomiting is when gastric and often small intestinal contents are propelled up and out of the mouth. So up to and also out of the mouth. It results from a highly coordinated series of events that could be described as the following series of steps. So this is the actual steps of vomiting, the actual process of vomiting. So you're going to take a deep breath. So a deep breath is taken, the glottis is closed, the larynx is raised so that the vomitus doesn't go into the trachea. So the larynx is raised to open the upper esophageal sphincter. So the upper esophageal sphincter is going to open. The soft palate is elevated to close off the posterior nares so that the vomitus doesn't go into the nostrils. So the soft palate is going to be elevated. The diaphragm is going to contract, so is contracted sharply downwards to create negative pressure. So the diaphragm is contracting downwards to create negative pressure. So it means the abdominal pressure is going to increase, the thoracic pressure is going to reduce. That will create a negative pressure in the thorax, which will facilitate the opening of the esophagus and distal esophageal sphincter. Then simultaneously with downward movement of the diaphragm, the muscles of the abdominal walls are vigorously contracted, squeezing the stomach and elevating intragastric pressure. So the intragastric pressure is going to increase. This is the pressure in the stomach. With the pylorus closed and the esophagus relatively open, the route of exit is clear. So now the content will move via the esophagus into the pharynx, from the pharynx into the oral cavity, then you vomit it. But if the volume is so much, sometimes the vomiters can actually find their way into the nares, the posterior nares, then into the nostrils. So you are vomiting from your nose, from your mouth, sometimes even from your ears, because there's a connection between the oral cavity and the ear, and also there's a connection between the ear and the nose. So the nose and the ear is somehow connected. So sometimes you find that there are those foramen that are there that can also result into something coming out of your ears, but your ears actually. But that one is very rare. But in most cases, you're just vomiting from your oral cavity and also from your nose. Okay. So there's a video that is just illustrating vomiting. So at your own time, you can watch the short video to illustrate vomiting. Otherwise, we are done with motility.